Good evening, everyone. Myself, Dr. Heenal Padalia from Medical Affairs Mankind. It is my pleasure to welcome you all to today's session, Boon Beyond Boundaries. We are connected here today to explore, discuss, and share knowledge on a topic that is of great importance in the clinical practice, which is titled Optimizing Medical Management on Endometriosis. As we know, the medical landscape is constantly evolving and it's an ever changing process. So, to stay informed and engaged with the latest developments, today we have the privilege of hearing from an expert, Dr. Kundan Ingle, who will provide valuable insights and foster meaningful discussions in the topic of endometriosis management. He is a director at Nirmiti Clinic, which is Center for Assisted Reproduction and Endocrinology, Pune. He is a chairperson at AMOGS Endocrinology Committee for the year 2024 to 2026. He was also the chairperson at Infertility Committee FOXY 2020 to 2023. He was also the managing council member. He was vice president of POGS 2023-2024. He has presented a research paper at ASRM 2020 on prospective RCT of estradiol valerate versus estradiol hemihydrate in AFT. It is of immense pride that he presented first time paper research at 6th COGI World Congress at Vietnam on the use of GCSF subcutaneously for thin endometrium. So I welcome Dr. Ingle to please take this session forward. Over to you, sir.
Thank you, Hinal, for those kind words of introduction. Good evening, ladies and gentlemen. First of all, at the outset, thank you very much, Mankind team, for inviting me for this gathering. And today I'm going to speak on optimizing medical management of endometriosis. So I think it's a very important topic, and I think we do see lots of endometriosis cases, and it is still on rising and rising over the day. And we know that surgical therapy as well as medical management, both options are quite helpful for the patients. But as we know, when it comes to infertility or any stage of woman's life, when endometriosis impacts on her life, I think medical management is somewhere considered as the best conservative management than any surgical management, which is sometimes very extensive, and it may also lead to recurrence, slightly better, a higher recurrence rate, which medical management may not have, because medical management works for a prolonged time, maybe over 24 months, or over even 5 years till now, with many updation in the medical management. So to begin with, let me tell you about slight introduction about endometriosis. And we must understand that endometriosis is, as we know, that there is a presence of endometrial like tissue outside the uterus. But what is important, and this is these three words which will best describe endometriosis, and that is chronic inflammatory reaction. Chronic means this disease is going to persist for a long time, and all the symptoms, it starts from endometriosis associated gynecological pain, dyspareunia, severe dysmenorrhea, or any chronic pelvic pain, or any infertility scenario. It is all related to this inflammatory reaction which is present around these lesions, and that is a main pathogenesis of endometriosis. Karl Rokitansky has discovered this endometriosis in almost, it is seen in 2 to 10% in general female population, and when it comes to infertility population, it is almost 50%. But when it comes to chronic pelvic pain, patients group who is presenting to us with a chronic pelvic pain, it is seen for almost 90% patients, they are considered to have endometriosis. So a patient when presents to you with a severe dysmenorrhea or severe chronic pelvic pain, which needs NaCID to control it, I think you must understand that it is endometriosis as proven otherwise. Now, as I said, there are two major problems, in endometriosis, and one is a pain, that is pelvic pain, which may be associated with menses or may not be associated with cyclical menses, or second is infertility. And whenever we are discussing about medical management, I think the first indication is endometriosis associated pain. Now, where exactly and what kind of molecules are available for medical treatment? So we know that so many decades we have used combined oral contraceptives as a first choice for almost, I will say, 5 decades. We are using the same drug. Then we realize that when endometriosis is a hyperestrogenic condition, why do we need to supply estrogen? Best thing is the progesterone, and then comes a role of oral progesterone, and in that, Dynogest is the molecule which came in later and proven its importance and positive impact on control of endometriosis. So they became a first line drug. There were certain previously used drugs which will induce hyperestrogenism, or they may antagonize estrogen action, and one of that is a danazol. But we know danazol has got a lot of side effects, androgenic side effect. We do have a GnRH agonist which we can use. It's a very effective drug, but we cannot use it for a longer purpose because of its side effect on osteoporosis. And also the third choice is a GnRH antagonist. We used to always hear, and we used to always look at this slide, and we always used to say like, yeah, GnRH antagonist is one option, but why it is written at the bottom? Because the unfortunately, whatever antagonists were available was injectable. You need to take a daily injections, and for a prolonged time period, it will be very, very, very expensive affair. So the available preparations were not in favor of using those as a first or second line drugs, and that remained as an experimental therapy. But now, as the technology advances, as the time evolved, so we do get these molecules which are coming easily, and these are the areas where we start using these drugs. So when is the medical treatment required? So one particular scenario is first line treatment, means when we see such patient, first thing comes in our mind, no, here only medical line of treatment is necessary, not surgical. And these scenarios are like adolescent endometriosis, that is endometriosis present in women or girls who are in adolescent phase, right from 13 to 18 to 20 age, or also those reproductive women who have finished their treatment, who have finished their family, and they do have a symptomatic endometriosis, so we want to control them. Also, premenopausal women, which are elderly women, who presents to you with a chronic pelvic pain and endometriosis associated pain, also are the best, one of the best options. I have also found out one very important group, which generally comes immediately after marriage, and they come for the pain symptoms, but they desire pregnancy, but they don't want now. So even if they are going to take 1 or 2 years, it's good idea if you have diagnosed them to have endometriosis. It's a good idea to give them medical line of treatment and suppress the disease till they till the time they decide to have a child. So again, it's a very, very useful group of patients, and it works very, medical therapy really works in this area. Second indication is after surgery to reduce recurrence. Now, again, we have seen grade 4 endometriosis where it is extensively pelvic area is involved, and sometimes it is so extensive that surgically it is difficult to do 100% job. Maybe we particular surgeons are not so skillful, and such patient may land up in recurrence. And when we have such kind of scenario, so we want to avoid recurrence because we could not do a complete job of by surgery, and that is why it is important that to suppress post-operatively these patients for to prevent recurrence or to avoid recurrence of the disease. Third indication, when the surgery is not possible or refused. Now, this is the scenario which where we may have that patient physically not fit to undergo surgery, or probably for social reasons she is not able to undergo this kind of surgeries. So there also, to buy time, we can go for medical line of treatment. As I said, adolescent young girls with endometriosis related pelvic pain. I think this group, till now, lot of, I mean, till last 7 years before, we have seen that surgical line of treatment was quite common in this age group. But now, in fact, 98% cases, we don't want to operate on these girls because we know that they still have to go to the reproductive life. They still have to reproduce. They still have to conceive. And we don't want any damage to their pelvic organs or reproductive organs, which will make them land in a situation where they might have to think about third party reproduction. Fifth indication is the scar endometriosis, and scar endometriosis also one of the very good indication where that ectopic endometrium giving a pain at the scar, and it works better. I mean, medical therapy works better in even such scenario. Again, adenomyosis is also seen to be better because it's nothing but it's endometriotic implants or ectopic endometrium in myometrium. And again, the pain which is associated, severe dyspnea which is associated with adenomyosis gets very, very well controlled by medical management. So, friends, endometriosis should be viewed as a chronic disease that requires a lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedure. Is what we are looking at as a goal of the medical treatment. Now we know, I will speak about some few slides about Dynogest, because as we know that Dynogest has got four important mechanism of actions. One is a anti-angiogenic effect. We know that there is a angiogenesis constantly happening around endometriotic implants. So that effect is reduced because of effect of Dynogest on VEGF. So Dynogest decreases VEGF and it prevents angiogenesis, and that helps for atrophy of the endometriotic implants. Or second effect is the immunomodulatory effect, where it decreases the tumor necrosis factor alpha, and that's how it improves the endometrium receptivity too. It has also got an anti-inflammatory effect by decreasing the prostaglandins. And as I said, majority of the symptomology is because of inflammation. So with Dynogest also has got similar anti-inflammatory action. The most important mechanism by which Dynogest stands out than any other previous drug, and that is pro-apoptotic effect. Apoptosis is a degeneration of the cells, or degradation of the cells. So it decreases BCL2 gene, and because of which there is the initiation or augmentation of apoptosis, and that leads to disappearance of the disease. So ultimately, all four mechanisms, they reduces the pain, and that's why Dynogest has proven to be a better drug which gives fantastic results in controlling the pain. We know that Dynogest was part of the contraception, but most important indication nowadays for Dynogest is to control pain, which is related to endometriosis in adolescent, in reproductive age group, and also in cases of recurrent endometriosis. Now, these were the initial studies in 2010, where Dynogest by Dr. Strovsky, he did a randomized open label active control multicentral trial, and it was compared, that is Dynogest was compared with leuprolide acetate 3.75 milligram intramuscularly every 4 weeks for 24 weeks, and VAS score, which is a score for dysmenorrhea or pelvic pain assessment, that proved that both the strategies, they effectively, efficiently reduces this overall reduction in pelvic pain, and the reduction in the pain is also significantly more better in Dynogest. And if you look at the safety profile, overall incidence of hot flushes was more in leuprolide acetate, but that was absolutely low in case of Dynogest. And mean incidence of hot flushes was also high in leuprolide group, but very, very low in Dynogest group. So, that way it is side effect profile wise, it is quite a safe drug. Now, if you look at the comparison of side effect profile of Dynogest with leuprolide and wanted to see whether is there any effect on bone marrow density. So yes, we know that leuprolide is associated with osteoporosis or osteopenia, and that kind of side effect which we don't see at all with Dynogest. I mean to say that significantly we do see 5-7% bone loss, but that is when you use more than 2 years, but probably not so significant like what you see on leuprolide acetate if you go beyond 3 months to 6 months therapy. So it was proven that Dynogest 2 milligram has demonstrated equivalent efficacy, and it has got advantages in safety and tolerability. Now, let us discuss about a newer drug. So, any new technology, any new molecule, any new process will always bring a hope, and that's how a next generation, drugs for endometriosis treatment is now here, and that is nothing but elagolix. Now, elagolix is a GnRH antagonist. We know that GnRH antagonist acts at the GnRH receptors, which are present at pituitary level, and they immediately antagonizes the receptor, and there is no release of FSH-LH from the pituitary, and that's how pituitary downregulation happens. That's how ovarian suppression happens. That's how estrogen and progesterone levels are reduced so significantly that patient land up in amenorrhea and for some time. So it's like a completely shutting down the system for some time, so that even endometrium at ectopic site, that is endometriotic implants, will also be able to dry up and cure the disease. Now, if I have to tell you about the molecule, it is oral, non-peptide, second generation. It's a GnRH antagonist. In July 2018, USA FDA approved elagolix tablets for the management of moderate to severe pain associated with endometriosis, and it is commonly available in India as a 150 milligram or 200 milligram tablet form. It is not only, rapidly absorbed, but it has got a plasma half-life of 2.4 to 6.3 hours, and it is metabolized mainly in liver and 90% excreted in feces. So in patients with normal liver function or mild hepatic impairment, so that is what is child puke classification. And if you talk about class 1, that is grade A category patients of hepatic impairment, they are very mild hepatic impairment, or maybe they have normal liver function and no coexisting conditions of hepatic pathologies. The recommended dose of elagolix is 150 milligram once day for less than 24 months. But in patients with coexisting dysmenorrhea, means those patients who's got endometriosis and dysmenorrhea and associated dyspareunia, I think higher dose is required. There we want to use it as a 200 milligram twice a day for almost 6 months. That much time duration therapy should be considered. In child puke classification category B, where there is a hepatic impairment is in a moderate amount. So in these patients, the recommended dose is lower always, because 150 milligram once a day for 6 months. For moderate hepatic impairment, please do not use higher dose of 200 milligram twice daily. So go with a lower dose of 150 milligram once a day. Now, what are the contraindications for elagolix? So, most important contraindication is a pregnancy. We will understand what impacts it can create if we give it during pregnancy. So, pregnancy is a contraindication. If patient already has severe osteoporosis even before we start any therapy, where the BMD2 score is less than minus 2.5, I think do not start elagolix. Also, the severe hepatic impairment, that is category C of the classification which I mentioned about hepatic impairment. So please do not give elagolix in this group of patients. Also, if the patient is concomitantly simultaneously using strong organic anions transporting polypeptide, that is OTP, so 1B1 inhibitors. So if you are using these drugs, probably do not use elagolix because there are certain drug interactions. So remember these four important contraindications. And if you look at the mechanism of action of GnRH antagonist, we know what agonist does. So I mean natural GnRH hormone does that. It binds to GnRH receptors, it stimulates the release of FSH and LH from anterior pituitary, and ovarian steroid hormone is released in the form of estradiol, and there is a normal menstrual cycle in natural cycle. But what happens with elagolix, which is a kind of a GnRH antagonist? So it competitively blocks the GnRH receptor. So as soon as you give elagolix, it goes and gets attached to GnRH receptors on pituitary, and it doesn't allow this GnRH endogenous GnRH hormone to get attached to the receptors. So it all depends on the dose dependent suppresses the production of FSH and LH from anterior pituitary, because there is no stimulation by GnRH which is coming from hypothalamus. The FSH LH production gets suppressed, and thus it inhibits the secretion of estradiol without inducing flare-up effect. Now that flare-up effect is generally with the GnRH agonist, but in antagonist we do not have a FLIR effect, and we can still can have lower secretion of estradiol. Now, if you look at the diagrammatic representation, please look at the lower kind of graph where it is in those squares. So in pulsatile GnRH release, so what happens for the GnRH receptor? There is an endogenous GnRH is getting attached. So as soon as the in natural cycle there is an increase in the FSH and LH, and then it reduces and it remains there. So that is what is natural cycle. But in depot GnRH agonist, what happens, as you see in the second box, the depot GnRH agonist, it acts at the GnRH receptors, and it completely empty the pituitary at the beginning within 48 hours. So what happens in estradiol levels, that there is an initial rise within 12 days, and then it keeps falling and falling and falling, and it goes very very low, where we can cause it as a severe hypoestrogenemia. So agonist is the one thing which can be utilized. Now when it comes to antagonist is going to immediately block the receptors where your pulsatile GnRH or the hypothalamic GnRH will not at all get attached, and then immediately you get a lower estrogen levels, as you see in the down lower graph, that there is an immediate lowering in the estrogen levels, serum estrogen levels, and it remains low, and it causes hypoestrogenemia. But with antagonists we do not get so low that where the it goes in below the threshold where you start calling hypoestrogenemia. So it still remains slightly up. Now, if you look at the how much low estrogen can go with these two doses schedule of elagolix, so when you are using 150 milligram once in a day, the estradiol concentration which gets suppressed to close to 42 picogram per ml, and with elagolix 200 BD, which is like a high dose which will suppress the estrogen production to 12 picogram per ml, which is like a strong suppression. So whenever you have a slightly less severe pain symptoms, you can go for 150 milligram once in a day elagolix. But complaints like severe dyspareunia or severe dysmenorrhea, you should go for 200 milligram twice a day orally, and because that will give you those so low levels of estrogen that there won't be any inflammatory reaction or activation of endometrium cells, which can lead to different symptoms. Now, we have to understand, and we always look at the evidence, how does it support our new molecules? And this was a very important study in 2017 regarding treatment of endometriosis associated pain with elagolix. And just to name this trial, which is called as ilaris em trial. So now ilaris em was, when it was planned in two phases. So phase one, that is called ilaris em1. So it was done on the population which is present in the United States of region, and ilaris em2 is the other 5 continents where other population exists. So all these patients, they received elagolix, sorry, they received elagolix in different doses. So we had one control where we do not we gave only placebo. In a second group we gave 150 milligram once in a day, and a third group where we gave 200 milligram twice a day. And what they realized when they compared these three groups for proportion of women showing clinical response in terms of reduction in the dysmenorrhea at 3 months, as you see, placebo has got a very very low proportion of women, that is 19%, who had a clinical response at 3 months. But as you keep on increasing doses, there was significant, that is like 200 milligram BD, it was 75% proportion of women having good clinical response at the end of 3 months. Same applied to non-menstrual pelvic pain and dyspareunia, that if you use 200 milligram per day, twice a day, I think it gives you immense control on this symptomology. Now, similar effect was seen in for other population which are from other continent. So it was, if you look at the compare the upper and the lower graphs, I think probably you will accept it that there is not much different response as continent wise. Even if the patient comes from US, from South Africa, from Europe, from Asia, I think probably it will work in a similar fashion. And when it was compared that, dysmenorrhea, that is proportion of women showing clinical response at 3 months, especially in controlling dysmenorrhea, I think 200 milligram twice a day has been proven that it is clinically significantly reduces dysmenorrhea in comparison with 150 milligram once in a day. Now, so finally, the conclusion of these initial two studies were that 200 milligram twice a day has exclusively shown efficacy in reducing the dyspareunia score as well as sexual intercourse dimension of EHP 30 score. So benefit of elagolix extend beyond reducing pain symptoms. So there were other than pain symptoms, whether elagolix is possible to control it. So this article in 2020 reviewed the non-pain systemic manifestations which are associated with endometriosis, and it summarizes the beneficial effects of elagolix on non-pain outcomes, and these includes improvements in quality of life, reductions in fatigue level, and improvements in workplace and household activities. So when they concluded this study, there were 1,270 patients who participated into this study. So gains in percentage of scheduled workplace productivity per week at months 3 and 6 of treatment, mean gains in the percentage of scheduled workplace hours worked defined as 1 into LS mean change from baseline in percentage of scheduled workplace hours, means how many hours that person could work with even the symptoms are persistent. So of course with severe dysmenorrhea or probably severe endometriosis, people could not tolerate sitting for a long hours. But I think with the drugs, this concluded that elagolix has an impact beyond pain symptoms, and it gives you a better quality of life. Not only that, it allows you to work, your productivity capacity at workplace is per week is extremely important, and it significantly increases when you're using it for a prolonged time like 6 months with 200 milligram twice a day. So also, if you look at the reduction in the fatigue, so the more higher dose you use, there is a more reduction in the fatigue, and that is very, very important. So 10 minutes. Okay, so elagolix 200 milligram twice a day has achieved higher improvement in patient-reported outcomes when it comes to reduction in fatigue. So again, these are the different parameters which are affecting her quality of life. And as we collectively say that, if we see this improvement into this parameter, the quality of life also, patients' quality of life is also better. Then comes ILARIS 3 and 4 trials, which were extension of the previous studies. So as you saw in ILARIS EM1 trial, of 249 patients were targeted, or selected for to receive 150 milligram per day dose, and 196 patients completed, and out of 196, 149 patients also participated in ILARIS 3 trial, which is the extension of this trial, but with the same doses of 150. Like that, in ILARIS EM1, there was another group which was 200 twice a day, and 183 patients completed, and 138 participated into second phase. Again, it was also applied to the other continent. So LRS EM2 part, which came out. Now the conclusion of this extension trial was the responder rates among women with moderate to severe endometriosis associated pain treated with elagolix 200 milligram twice daily were approximately almost 78% for dysmenorrhea, 70% for non-menstrual pelvic pain, and 60% for dyspareunia at the end of 12 months of treatment. So those important symptomology or impact of symptoms on the woman's health, I think that is significantly improved if you give elagolix 200 milligram twice daily. And the responder rate, that is, even if you're giving a drug, the responder rate among women treated with elagolix of 150 milligram was more than 50% of the women demonstrated a clinically meaningful response in terms of dysmenorrhea, non-menstrual pelvic pain, and approximately 45% had a clinically meaningful response in dyspareunia. The use of rescue analgesic agents. See, we know that the pain is so severe that patient needs NSAID. So, what was the chance that they needed, additional drugs like opioid use? And they found that greater than 30% mean reduction at 150 milligram once a day was achieved, and greater than 65% mean reduction at 200 milligram twice a day has been achieved. So, the important point is here is that if you continue giving them, the percentage of improvement in dyspareunia or chronic pelvic pain keeps on increasing if you continue the drug. As we understood about Dynogest, we have to understand about even the safety profile of elagolix. And when it comes to such drugs, when they are causing severe hypoestrogenemia, we have to find out, is there any impact on bone, is there any impact on liver, is there any impact on lipid profile. So this was a study which they wanted to see the side effect profile of elagolix. So the commonest side effect of hypoestrogenemia, and that is hot flushes, was seen in almost 24% of 150 milligram group patients, which was very high. That is 48% that received 200 milligram twice a day. We know that there is a significantly lower estrogen levels with elagolix 200 twice a day, and that's why we see incidence of hot flushes is too high in this group of patients. The study drug discontinuation, that is important again because of the side effect like hot flushes. We did not see that patient voluntarily wanted to discontinue the drug. That was only less than 1% in elagolix 150 milligram, and with 200 milligram it was less than 3%. So hardly any difference. Patient could continue the study without any intervention. And also similarly, we wanted to know whether is there any impact on bone marrow density. Like Dynogest had a minimal impact, but leuprolide acetate has a biggest impact on osteoporosis. So, of course, with elagolix, what is the situation when it comes to soul holo level of estrogen levels or estradiol levels in blood circulation? So, what we found in this study in 2021, that mean percentage change in lumbar spine bone marrow density when patient received 150 milligram once a day, it was only reduction was by 0.3% to 0.7% only. If you use 200 milligram twice a day, the reduction in the bones lumbar spine BMD was in the range of 2.5 to 2.6%. So that was suggestive that it does not have a significant impact in reducing the bone marrow density, just like Dynogest. And when you stop the therapy, almost 50% recovery in the bone marrow density happens at the end of 6 months and 12 months post treatment. What about the lipid profile? I think when it comes to lipid profile, I think Dynogest has proven that Dynogest has got no impact on lipid profile. Let's see what elagolix has. So what elagolix in group of patient who received elagolix, dose dependent increases were observed in total cholesterol, low density lipoprotein cholesterol, high density lipoprotein cholesterol, and triglycerides. So the more higher dose you will give, probably the more chances that you may see impact on the lipid profile. So lipid increases occurred primarily during the first 1 to 2 months of treatment only. This is the beauty of this product. So only first 2 months is what we are worried about. Otherwise, if there is no impact, we don't need to monitor every once in a month or at the end of therapy or completion of therapy. So reduction to the baseline lipid profile occurred within 1 month of discontinuing treatment. So it is like even the recovery is very, very good when there is a affection on lipid profile. What about the other mild side effects? So what we see is a headache in some few patients sometimes, and insomnia, mood swings, night sweats, which probably associated with hot flushes or joint pains. But with elagolix, there was no adverse effect on the endometrium. So friends, it's a good drug with a very, very safety profile. Let us see what we need to follow, especially when it comes to safety and pregnancy, I mean, safety in pregnancy. So we must understand that elagolix reduces estrogen levels so low that it might cause, if you are taking a elagolix during pregnancy, it will cause a chorionic tissue degradation and degeneration, which may land up in a patient may land up in a miscarriage or IUD. So pregnancy should be discouraged first of all in women taking elagolix. But even if you are taking elagolix, ovulation is still possible in some few patients. So you need to be careful that patient has to be counseled very well about these impacts, that there is a chance of natural pregnancy even if you are taking elagolix. So some contraception they have to follow. Even patient who has conceived or spontaneously or naturally when she was on elagolix therapy, they found that almost all those patients have shown presence of congenital malformations in all the reported pregnancies. Now, that is why it is recommended to use non-hormonal contraceptives during elagolix treatment and for 1 week after discontinuation of the therapy. So estrogen containing contraceptives are better or progesterone containing? So estrogen containing contraceptives are not recommended in women treated with elagolix, as the introduction of exogenous estrogen may lower the treatment efficacy. That's what we discussed in the beginning. Otherwise, we would have used oral contraceptive pills. So progesterone may add benefit in controlling the endometriosis and may be considered. The potential influence of progesterone only contraceptives on elagolix efficacy is not yet been studied, so we don't know. Progesterone releasing intrauterine system may provide contraception and augment the treatment of endometriosis, because we know that in endometriosis associated adenomyosis or even in endometriosis associated dysmenorrhea, if you use LNG IUCD, I think it gives you fantastic symptomatic control. So uh, this kind of IUCDs used during elagolix will give that additional contraceptive effect also, so that patient should not get accidentally pregnant, and patient who became pregnant while elagolix should immediately discontinue the therapy. So friends, to conclude my talk, elagolix is the first novel non-peptide orally active GnRH antagonist, very effective for the management of moderate to severe endometriosis associated pain and heavy menstrual blood loss associated with uterine fibroids. Also, it competitively inhibits GnRH receptor at pituitary gland and leads to rapid and dose-dependent reduction in circulatory gonadotropins and ovarian sex hormones, including estradiol. In women with endometriosis associated pelvic pain, both higher and lower doses of elagolix were effective in improving the dysmenorrhea and non-menstrual pelvic pain during 6 months period and sustained pain reduction during long-term extension studies. It offers a new medical treatment option for management of moderate to severe pain associated endometriosis. The recommended treatment duration with elagolix in women with normal liver function or mild hepatic impairment is up to 24 months for 150 milligram once daily and up to 6 months for 200 milligram two times per day. So just to summarize and brush up, friends, that I think we must gain the knowledge how to use these drugs, how they are going to help us to kind of control the disease. When we have already drugs like Dynogest, I think lots of advantages, and even this elagolix has been studied into groups of patients who presents to you with a heavy menstrual blood flow, or even patients of undergoing IVF as a pituitary downregulating agent. We are also planning and doing the use of elagolix into IVF sector in particularly selected patients. So once those studies will get complete, maybe we will be able to widen the spectrum of use of elagolix in different scenarios in gynecological problems. And that's what I wanted to present to you today about optimizing medical management of endometriosis. So thank you all my friends, and thank you team Mankind for giving me this opportunity to speak in front of this August audience. And if there are any questions, Hinal, I will love to answer those questions. So over to you, Hinal.
Yes, sir. So during our session, we had received few questions during your session. So the foremost is the like we you very briefly discussed about the Dynogest as well as elagolix, but I guess dydrogesterone has also the recent papers are surfacing for the immunomodulatory and anti-inflammatory role of dydrogesterone, which is a later generation progestogen. So can you highlight the cure rate for the endometriosis with dydrogesterone because it also occupies a major chunk for the medical management of endometriosis, sir?
Yes, I think dydrogesterone, use of dydrogesterone in endometriosis has been now we are using it into those women who desire to have a pregnancy. So those grade 3, grade 4 endometriosis patient who also has a pain but also desire to have a pregnancy. So when we treat them, because dydrogesterone has this unique characteristic that it do not suppress ovulation completely like what other drugs will do. So there is a good chance that a patient can still ovulate spontaneously even if after taking dydrogesterone, and she still can conceive. And I think for a reproductive age group woman, and having known that she has endometriosis but she's trying for a pregnancy, I think instead of putting them on elagolix or dynogest, I think dydrogesterone is the one drug which is more safer and should be used, this particular group of patients.
Thank you, sir. And another question is, how do you rate the Dynogest in managing pelvic pain as compared to dydrogesterone? Because somewhere improving the quality of life of a patient with endometriosis is what we are aiming at, right? So how would you rate the pain management in the endometriosis patients, sir?
Okay, so I think first of all we need to understand that both are progesterones. Like Dinoges is a progesterone, dydrogesterone is a progesterone. Now, pain is typically due to the inflammatory reaction which is happening in endometriosis in the pelvic area, and it is very important that the more lower estrogen levels we can achieve, the more better pain control will be able to achieve. So here I will say that if you look at the dynogest, dynogest will effectively control the pain, though the dydrogesterone will do that. But if you look at the estrogen levels which will be achieved by dynogest, they are in the range of somewhere close to 45 to 50 in the circulation. But with dydrogesterone, they are not so suppressed. So if you want to use a molecule which is used for a suppression of pain for a longer duration, dynogest is better. But if you have patient who wants to conceive and also have a pain where you want to reduce the incidence of pain, I think this is the group where for shorter time you put them on dydrogesterone for 3 months, and after that, even if she doesn't conceive, you can decide which type of ART she needs, and you can proceed with after you stop dydrogesterone and some few days of washing out period, and you can continue as soon as she gets her next menses, you can immediately start ART treatment.
Surely, sir. So I think one of the question was is in continuation with same line. So what is the like which ovulation induction you prefer in cases of endometriosis patients? Because infertility is a major problem for the endometriotic patients, right? So ovulation induction in endometriosis, if you can highlight few pointers, sir.
You mean to say for IVF protocols?
Yes.
Yes, I think, okay, that's a very good question. So I think my decision of down regulation of pituitary, that is pituitary down regulation protocol when it comes to IVF, will more depend on the ovarian reserve rather than anything else. So for example, even if patient has a endometriosis, still they have a very good reserve, or they may have even they are hyper responder, they have a excessive ovarian reserve. So in this scenario, I think antagonist is the first choice always, because I can use agonist as a trigger and freeze all embryo. But when it comes to say poor reserve patients and endometriosis, which is in fact more common cause, because endometriosis destroys ovarian reserve. So in such scenario, my intention to use down regulating agent like GnRH long protocol, agonist protocol will be my first choice, because first of all, it can give me a synchronous follicular growth. And because of GnRH agonist, we may get a pituitary downregulation very well. So it gets associated that, endometriosis associated inflammatory reaction goes down. So the endometrium receptivity is better, the oocyte quality is better, and that's the advantage where we will in a low reserve patients, probably my choice will be day 21 long agonist protocol.
Thank you very much, sir. And last but not the least, sir, like, is there any associated risk of preterm delivery, preeclampsia, or prenatal hemorrhage, or a placental complications in a pregnant woman with a history of endometriosis? Like these cases, is it predominantly seen with a history of endometriosis,
I
sir?
think these kind of, especially, when you said about placental abnormalities, I
Yes.
mean, retained placenta, adherent placenta. So typically you see these kind of situations during pregnancy in those patients who had a adenomyosis before pregnancy, because that's where the endometrial-myometrial junction has been breached, and sometimes you may get a placental accreta or increta in such patients very commonly. But those normal uteri, but having pelvic endometriosis, these complications are like preterm delivery or preeclampsia. It
Preeclampsia.
is not related to per se endometriosis, but it is related to for the IVF protocol which was used in such patients. Till now, even before our recent ESHRE guidelines in 23, before that, what we used to do is to use a freeze all embryo strategy and ask those patients to undergo frozen embryo transfer, where we used to use a protocol where leuprolide agonist depot was given for 3-4 months, and during that suppression estrogen was given for prolonged time period, and then embryo was transferred. So that down regulation HRT protocol is known to have such a high incidence of preeclampsia, large babies, postpartum hemorrhage, preterm deliveries. So it's a side effect profile not related to endometriosis, but the protocol which was used. Now 23 onwards, the guidelines have changed. They said that there is no need of prolonged suppression of pituitary before FET cycle by leuprolide agonist depot. So now we don't do that kind of practice, but we still do in certain endometriosis patients frozen embryo transfer. So there, in fact, what we prefer is to do a either a natural cycle when a patient is ovulating well, or regular cycles, or ovulation induction cycles with letrozole as a HRT as a endometrial preparation protocol. But with this side effect, we don't want to use a frozen embryo transfer protocol, HRT frozen embryo transfer protocol.
Surely, sir.
Uh, Dr. Hinal, I would like to pose one more question to sir,
Yes, sir.
since we were talking about frozen embryo cycles. Sir, what is the luteal phase support protocol you use in such a patients of endometriosis? Is there any specific care which you wish to give to them, or any choice of molecule in these patients, sir?
Okay, I think in such patients when who has a endometriosis and ART has been done, I think these patients definitely need a very, very good progesterone support. And as Midron study has given us that if you combine vaginal natural micronized progesterone along with dydrogesterone, so both combining will have a better ongoing pregnancy rate and better clinical pregnancy rate. That has been, kind by concluding remarks after studying the evidence. So my choice will be combining both the drugs, natural micronized progesterone along with dydrogesterone. Again, if you ask me what kind of dose schedule we need to give, so at least 600 to 800 milligram in natural micronized progesterone and 30 milligram of dydrogesterone. Combining this will be my first choice as a luteal phase support for such patients.
Great, sir. Sir, you talked about that dydrogesterone can be used in the management of endometriosis. Any preferred dosage which you would like to recommend to these patients, that yes, whether it should be 20 milligram or 30 milligram, or what should be the cyclical or maybe intermittent regimen you will be recommending to these patients, sir?
Yeah. So it's a very good question, in fact. So whenever you are using only dydrogesterone and patient is also planning a pregnancy, so the preferred dose schedule is 20 milligram per day. That is where you are not giving a round the clock progesterone level, so that there is a uniform pituitary down regulation. So here the chances of spontaneous ovulation is more higher than your 30 milligram. But if you are using dydrogesterone as a whole agent for endometriosis, suppression of endometriosis associated pelvic pain, then I will like to give it for 30 milligram per day, that is 10 milligram 3 times a day. The whole reason is that if you are using a 10 milligram plain tablet, then it has got a half-life of only 5 to 6 hours. So we want to have a uniform circulatory levels. So in that scenario, you have to give 8 hourly, that is 3 times a day. Now we do have a sustained release preparations of dydrogesterone, where we do have a prolonged half-life for 15 to 16 hours. So we want to have at least higher levels of progesterone or dydrogesterone in the circulation. So 30 milligram SR will be the first choice when I'm not expecting that patient is desire of pregnancy or patient is planning for a pregnancy. So this is one. Then second question was your intermittent cyclical therapy. So sometimes the, patients do have, they are trying for a pregnancy. So what you can do is you can give patients in a luteal phase additional dydrogesterone, because it does have a, what you say, kind of post, anti-abortive effect through a lot of interleukins. So I think it will help you to even prevent miscarriages which may happen. So that's why even you can give progesterone in a luteal phase during this, during those all those patients who are even coming to you for dysmenorrhea with endometriosis.
Thank you so much, sir. With this, I would like to extend my sincere gratitude and sincere regards to Dr. Kundan Ingle for such an elaborative discussion on the management of endometriosis. I think all the attendees might have benefited from the medical management perspective of endometriosis. We look forward for such engaging sessions in the future. Thank you very much for joining in. Thank you, Dr. Kundan Ingle. Thank you, Dr. Hinal, for this session. Thank you very much.
Thank you, Dr. Ashutosh.